We are going to go through a review on the use of neuro-CT angiography. This is Adrian A. Harkin Valdivia. I have no financial conflict of interest. Disclaimer: the information is intended as an educational tool. It does not replace or overrule the treating healthcare provider's judgment, critical thinking, individualization of care or diagnosis. The information provided is subject to change in light of new discoveries or advancement, and because of human error on my side, it is up to the treating healthcare provider to decide the relevance, appropriateness of this material to their patients and their context. Users have the responsibility to confirm the relevance and appropriateness of the information here provided. You are responsible for the care of your patient. This material should not be construed as standard of care, or used in expert witness testimony. No guarantee is given regarding the accuracy of any statements or opinions made on the app and its content. Under no circumstances shall I be responsible for the damages arising from the use of software. You are responsible for keeping updated and observing if this app's content continues to be relevant for your use. Some of the items reflect my own experience. Use at your own risk. The app's content is provided as is. The objective of this presentation is an overview of the use of Acute Neuro CTA, technical and clinical overview. I am briefly exposing my pattern of thinking that hopefully may be useful to you. Plain non-contrasted head CT scan is essentially the imaging of densities. It is nicely suited to be used in emergency settings, in part because it is available almost in every emergency room, and has a relatively low price. The eye is drawn into deciding on the types of densities present, which will fall within the spectrum between hyperdensity, isodensity, and hyperdensity. Followed, observation of edema and mass effects. The effects of the lesions on the brain, or even on its own, ventriculomegaly or hydrocephalus. Some key questions when looking at a head CT scan are: is there a bleed in the brain? And if the bleed is in the parenchyma, it is most likely a neurological issue. If the blood is outside the brain, it is most likely a neurosurgical issue. When to bleed is not typical, neurology may be the first one to engage into workup to decide diagnosis and treatment options that may involve your surgery. On CT scan, the measure of density is done using the Hounsfield units, where 0 is the density of water, positive 1000 is the density of bone, and negative 1000 is the density of air. The density of brain in general falls between positive 20 and positive 30. Hyperdense things on the CT scan include bullets or metals, bone or calcifications, blood or acute blood clots, and contrast. Other things that may appear hyperdense include cataracts and pus. Isodense things include meningiomas, subacute blood, anemic acute blood, certain other tumors, or early or late phases of abscences. Hyperdensities included water or edema, cysts, fat, and air. Not all non-invasive cerebrovascular vascular imaging is created equal. The best of them is the CT angiogram, including the CT venogram. The second best test is an ultrasound, followed by an MRA with contrast, then an MRA without contrast performed on a 3 Tesla machine, then an MRA without contrast on a 1.5 Tesla machine, and lastly the transcranial Doppler. In the acute setting, performing a CTA should include both neck and brain. The amount of contrast is the same for either one or both. The amount of tissue exposed to radiation is obviously larger when both are performed. But in the acute setting, we also need to know the state of the neck vessels that are included for planning navigation through them. Emergency setting, the diagnosis of ischemic stroke is going to be accomplished by a combination of clinical and imaging characteristics. On the decision for alteplase administration, the time frame is 0 to 4.5 hours. But for endovascular therapy is 0 to 24 hours, when the NIH stroke scale is 6 or greater and the modified Rankin scale of 2 or less. So, if the patient meets criteria for acute endovascular therapy, then the patient should have a CTA of the neck and brain. If on the CTA there is an occlusion in an artery that is amenable to endovascular therapy, then and only then should the patient be considered for a CT perfusion study. If the patient is not a candidate for endovascular therapy, then the patient should not be given an acute CTA nor a CTP. This sample diagram with 4 circles steps exposes a way of thinking through each one of the neuroimaging studies on the way to endovascular therapy decision. CT scanning uses radiation, CTA and CT perfusion increase radiation exposure, and require the use of contrast agents. We are all submitted to background environmental radiation from different sources. One non-contrast brain CT scan will deliver about the same amount 1 year worth of background radiation, but over few seconds. A CTA of the neck and brain will deposit 6 years of natural background radiation, in a few seconds, which will increase the risk of 1 additional cancer occurring in every 2,000 patients 60 years old or older that get these studies. This cancer effect is 2 to 3 times higher in younger people. CT contrast can also lead to allergic reactions. Because most CT contrast contains iodine, it can lead to thyroid dysfunction including thyroid storms. Because of these well-known risks, we need to diligently observe which studies will be beneficial to the patient and limit to only those. Convenience to the physician is not an indication to get a test done. Some strengths of performing CTA included how fast can be performed, how available that technology is. It can give a sense of the perfusion of the tissues, it only requires a peripheral for, can detect even small things such as 1 to 2 aneurysms, and even find if there is ongoing active bleeding in a hematoma by put into evidence the leak of the contrast into it. Some limitations of CTA include difficulty ascertaining the direction of the flow. For example, there may be retrograde flow which will be impossible to determine, or answering the question of collateral flow, or ascertaining the speed of the flow which may be relevant in arteriovenous malformations, in cases where there may be a dural venous fistula. Since many of these lesions are going to be right next to the bone, it may be impossible to find them. If there are proximal stenosis on the artery of interest, that may complicate the interpretation of a CTA. Also, if there are multiple stenosis in multiple arterial territories, may make the interpretation very challenging. So, about 20% of the cardiac output will go to the brain, which means that about 20% of an 80 ml bolus of contrast will end up in the brain circulation. Always keep in mind, some additional potential limitations, for example peripheral venous thrombosis on the side of the injection, large pulmonary embolism, severe congestive heart failure, or hyperkinetic cardiac function, which can either decrease or increase the circulation time. When interpreting CTA, it is imperative to keep in mind the path of the bolus. The contrast will be injected in the peripheral vein, flow through the subclavian vein into the superior vena cava going to the right heart, flows through the lungs, gather itself back into the left heart and then be ejected into the ascending aorta, from where it will go everywhere. 20% of this will end up in the carotid and vertebral arteries, flowing to the brain arteries, branching to the arterioles, flowing through the capillaries, collect back in the venules and into the large cerebral veins, then out of the brain into the neck through the jugular veins, back into the chest into the vena cava. Following the path of the contrast needs to be done 4 times, in every one for every brain main arteries, once for the right carotid, then for the left carotid, then for the right vertebral and then for the left vertebral, and in the 3 planes. This diagram shows the location of the bolus flowing over time from the large arteries into the capillaries into the large veins. This diagram shows the hyperdensity of the contrast bolus over time, as if you were spying on the contrast in one artery segment as the contrast bolus appears, peaks and then gradually gets flushed away and the bolus disappears. This diagram shows hyperdensity of the bolus as it transits through 2 arteries, a normal one in red and one with stenosis in yellow. The red one shows how the contrast comes in peaks and is washed away in a normal amount of time. In the yellow one, the contrast is slower to flow, doesn't peak as much and needs longer to be washed away. Therefore we have lower time to peak and increased transit time in the artery that has the stenosis. When interpreting his CTA, the key is to follow the contrast column one artery at a time, slice by slice. Let's say a patient has weakness on the right side, then our main focus is going to be the left carotid artery, and that's where you should begin, with it area most likely to be affected. Begin by looking and following at and from the aorta, then find the common carotid artery. If it is difficult to initially identify the connection between the two, then you can backtrack it from the common carotid artery slice by slice back down and connect the aorta with the common carotid artery. Then go back to the common carotid artery and start going upward into the bifurcation. Find the echa, continue to follow the echa up to the skull. The intrabone segment can be challenging, and at least for now you can skip into the intracranial internal carotid artery, find the bifurcation, and then follow the middle cerebral artery up to the M2 segments, as that is as far as the current stents are going to be able to reach to retrieve a blood clot. If there is no stenosis or cut-off, then quickly move to the posterior circulation to look at the vertebral and basilar arteries. Then, you can go back and take a look at the remaining arteries from bottom to top, front to back, and from side to side. You may also turn your attention to the amount of contrast in the tissue and compare side to side. Also take a look at the venous structures, and follow the contrast in the veins, all the way to the jugulars. Note that the mid-sagittal views will present to you a lot of vessels, such as the superior sagittal sinus, the inferior sagittal sinus, the deep cerebral veins, the sinus rectus, and a large amount of cerebral arteries in the distribution of the anterior cerebral arteries system, which could be useful in cases of vasculitis. Follow the contrast column slice by slice, vessel by vessel, on the axials, the coronals, and on the sagittals. Follow the contrast. In acute stroke, we're looking for clinically explaining or correspondent stenosis, cut-offs or occlusions that the retrieving stent can go into. Those are the up to the proximal MCAs and M2s and up to the top of the basilar. The normal adult MCA and basilar diameters tend to be between 3 and 3.5 mm. An ipsilateral carotid dissection or stenosis may not be a contraindication for endovascular therapy, as it could emergently be stented to reach the more distal clot. In the United States, we tend to use the NACIT criteria for determination of arterial stenosis. That is, we measure the maximum diameter at the level of the stenosis, and we measure the diameter of the normal artery distal to the stenosis. If in the carotid bulb, then measure the normal artery diameter just distal to the bulb. Then, plug those numbers into the formula and calculate the percent stenosis. Essentially, the question is, if the just distal segment is 100% normal, then how much is the stenosis at the widest point? You may need to look at the stenosis in the three planes, and adjust the window levels, as calcifications can make difficult to get the measurements. As you're looking at CTAs, your brain is going to have to be attentive to a series of possibilities, which include hyperdensities in the blood vessels, stenosis, dissections, and aneurysm and dilatations, also atypical aneurysms, AVM, FMD, vasculitis, vasospasm, trauma patterns, age of lesions, number of lesions, masses, atrophy, encephalomalacia, post-op changes, normal variants, symmetric edema, loss of gray-white differentiation, foramina, calcifications, as well as extra-brain areas such as the eyes, the orbits, bones, the bone marrow, the nasal sinuses, thyroid, lungs, mediastinum, other soft tissues. Practice will lead to perfecting. Some tips and pointers in interpreting CTA include: if a lesion has drawn your attention too much, then cover it and look without the distraction. When something feels atypical, think about potential venous thrombosis. Symmetric lesions can be difficult to spot, as the human eye tends to look for asymmetries. In some cases, slow flow may magnify the severity of the stenosis. Be attentive to accelerated contrast flow from arteries to veins, as may suggest an AVM. If there are prior studies, you are best comparing them to the new one. There is a contrast rule of 2s in stroke. Contrast enhancement begins within 2 days, peaks at 2 weeks, and disappears in 2 months. One note on venous thrombosis of the brain: most of these are going to be treated, and respond very well to anticoagulation treatment. Very, very few of them are going to need endovascular therapy, which will be contemplated when medical therapy is not improving it. Please remember to draw the hypercoagulable panel before anticoagulation is begun. Venous thrombosis is managed by neurology. Thank you very much. I hope you find the information here proves useful. Do remember that this is not a comprehensive discourse on CT and CT angiography. Appreciate your time.